Okay, I think my screen is visible and I'm audible. Okay.
Yes.
Yeah, Dr. Sriganesh is visible.
Yeah. Very good evening to all, and thank you, Dr. Zulfi, for asking me to speak on basics of research methodology, which is a topic of interest to me, and which I find will also be useful for all initial career researchers and clinicians who are interested in research. And of course, the trainees, be it DNB, MD, or DM, any of the courses that they are pursuing. So with this, what I'll be doing is I will try to address some of the common questions that raises in our mind when we discuss about research. So how to choose a research question? What should be the research design appropriate for the study that I intend to undertake? And how to write a good research proposal. Now, that is the first and the most important aspect when you plan a research. And the key steps that are involved in conduct of research. And lastly, how to share the findings of your study to the larger audience. So when we talk of research methodology, it is a way to systematically and scientifically solve a research problem, which is basically inherently arises from a clinical situation for those who are bedside clinicians as well. And learning research methodology helps researchers plan and execute research better than they would otherwise without a formal knowledge or training in research methodology. Now, when it comes to choosing a research question, most often these are some of the reasons why a clinician dwells into the realm of conducting research. Now, he comes across a bedside clinical problem that is not solved or still ambiguous, such as the example that I given here. You want to administer mannitol for a particular patient, and then someone comes up and says maybe hypertension has more evidence in the recent times, and then you don't know whether to switch over from mannitol to hypertension at bedside during the practice. And you go and find literature that the particular patient population that you are addressing, there is not much literature which says one or the other is better or superior in its efficacy or in terms of side effects. So you plan to compare these two in your particular population. So that's how a research question arises. The second is to explore a mechanism which is clearly not well understood. For example, the impact of propofol anesthesia on functional connectivity in the brain in health and in disease is not very clearly understood, despite in the recent past several articles being published in this area. The third area is to know there is a particular problem, for example, postoperative cognitive dysfunction. Now, I want to know whether the factors that contribute to postoperative cognitive dysfunction are similar in neurosurgical population as compared to the general surgical population, because there are certain unique factors that can predispose to postoperative cognitive dysfunction in neurosurgical patients. So I want to plan a study. So these are some of the questions that arises in the minds of clinicians when they are caring for their patients at bedside, which can be formulated in a very systematic and organized way into a research question, and then proceeded to get an answer for this particular research question. Next question that comes to mind once you decide, okay, this is the research question that I have, is to select an appropriate design to answer that particular research question. So some information is available on how to approach a research question. And most often we look at the hierarchy of evidence. If you look at this table, this figure, you know that the hierarchy, the topmost in the hierarchy is the guidelines that we most often follow in our practice to have better outcomes for our patients. Now, guidelines are essentially derived from systematic reviews. But once again, we must remember that there are guidelines which are available for some of the elements of care of patients, while for many of the elements of care, the guidelines are not available or unambiguous or ambiguous. So systematic reviews are what we rely on. Systematic reviews are again derived from the primary studies. And these primary studies, it could be a randomized controlled trial or it could be an observation study. Amongst the primary studies, randomized control trials are considered to be superior, and prospective observational studies, and then retrospective observational studies, and then case reports. These are the studies that are in the hierarchical order, which needs to be either performed or appraised during our practice. Just one slide each on the types of studies that can be undertaken to answer research question. The systematic reviews do provide very strong data, because it is a collation of independent studies, and you look at if it is an observation, if you want to say post-operative cognitive dysfunction example, the incidence varies from say 10% to 50%, depending on the population that you study, depending on when the assessment of cognitive dysfunction was done, depending on what instrument used for assessing cognitive dysfunction. So the incidence can vary. So there may be some 50 or 20 studies which report the incidence of cognitive dysfunction after surgery. And if you do a meta-analysis, there can be a point prevalence or a point incidence which you can obtain, which can tell you that this is the likely incidence in of cognitive dysfunction in this particular population. Similarly, for randomized controlled trials, systematic reviews, if there are 10 studies which are comparing ondansetron with the placebo, granisetron with placebo, or any other form of anti-emetic medications, and the outcome is post-operative cognitive dysfunction, you are not clear. Some studies will say ondansetron is superior, some say ondansetron may not be beneficial, some may say granisetron is superior. So the clinician at bedside is not clear which one to use for that particular population. And if there is a systematic review and a meta-analysis performed, which provides the evidence in a crystallized manner, looking at heterogeneity, and informs you, okay, ondansetron is beneficial or is not beneficial, that will help you in taking a decision at bedside. The next is the randomized controlled trials. As I mentioned, they are in the primary studies, they are the top of the hierarchy. And most often, this is a common study design adopted by the trainees during the part of their thesis or dissertation. So here again, we should be very clear how to perform a randomized controlled trial, because a well-conducted study can increase the possibility of subsequent publication. A well-conducted study increase the possibility that the findings of your study are taken into consideration during the clinical decision making at bedside. The next study design is the observational study design. It can be in various formats as mentioned here. The cohort study, most often it is a prospective in nature, helps in identifying the etiology, or it is most suitable for rare diseases, provides incidence, cause, and prognosis, measures in chronological order, so that we can correlate the cause and the effect. Whereas cross-sectional studies can help you in providing the prevalence of a particular outcome. It is very easy and quick to perform, but cannot distinguish between the cause and effect. And the other type of observational study is the case control study, again most commonly adopted retrospectively. Retrospective nature is possible. It also helps in identifying certain predictors and useful for rare disease when prospective observational studies are not feasible, and can help in generating the hypothesis for subsequent studies. Now I'm going to give an example of each of the study design. Here is an example of a prospective cohort study. Here we are looking at the effect of intra-arterial nimodipine on certain outcomes. And in this particular situation, it is regional cerebral oxygen saturation and certain cardiac measures. Now, this is important because intra-arterial nimodipine is a common intervention performed to manage cerebral vasospasm after aneurysm subpercutaneous hemorrhage, with the hope that nimodipine causes cerebral vasodilatation and thereby improves in, the neurological condition of the patient. And the neurological condition of the patient improves not only because of the increase in blood flow into the critical areas of the brain, but also because of the overall improvement in the systemic hemodynamics. Now, this particular study will help you in identifying whether the improvement in cerebral oxygenation is responsible for improvement in neurological status, and if there is systemic problem which can negate the benefit of cerebral vasodilatation. we almost in our clinical practice find that administration of intra-arterial limodipine selectively into the intracranial vessels can also cause hypotension, systemic hypotension. Now, what is the cause for systemic hypotension? Whether this systemic hypotension affects the benefit that is likely to be gained, and whether this is sustained. Now, these are not well studied, and therefore this kind of prospective study design can help in getting answers for some of these questions. Now, this is an example of a cross-sectional study. Now, this study looked at microbial growth in peripheral IV lines, and it found that around 6% of the samples had a positive microbial growth. The most common organism is Staphylococcus aureus, and there was significant association between presence of local signs, age, and positive culture, and flushing of the IV cannulas every 6th hourly associated with negative culture. So this is easy to do. You perform the study in all patients admitted in ICU simultaneously, and then look at the prevalence of a particular outcome. Case control study, an example is a surgical site infection. Here, because the incidence is very low, if you can see in this study, out of 2,500 odd surgeries, 1.3% of the patient developed surgical site infection. Now, this is very low incidence, and therefore, to look at the factors that are responsible for this may be very difficult unless you compare it with the control. And here the control is either in the same ratio as 1:1, or you can inflate the control in a proportion of 1:2, and then identify certain factors which can lead to the surgical site infection. Here they propose to study on the procedure duration, anesthesia duration, need the blood transfusion, etc., and outcome of occurrence of surgical site infection or non-occurrence of surgical site infection. So this way you can identify certain predictors for an outcome such as surgical site infection. So, so what is the purpose of a research proposal? Why do you need to write a research proposal before you start your research? Now, a proposal documents the details of your research works. It provides a blueprint or a plan of action of how you go about conducting your research. And it is a prerequisite for several things that are likely to be required for the smooth conduct of research, such as a departmental scientific committee, the Institute Ethics Committee, or if you're applying for funding, the grant submission agency might ask for a detailed proposal. And it is mandatory nowadays to submit your randomized controlled trials or any intervention studies to the Clinical Trial Registry of India if you are conducting research in India. And they also need a detailed research proposal. And lastly, if you plan to publish your study protocol, it also helps as a ready material to publish your protocol. So these are the reasons why you need to write a research proposal before you even contemplate or start your research properly. So this is the these are some of the examples of how you can publish your research proposal, convert your research proposal into a study protocol, and there are quite a number of good journals which accept this protocol. This not only helps in adhering to the proposed methods that you are going to adopt in conduct of your research. It also helps in terms of a benefit, in terms of a publication for you as well. So I have listed the steps in conduct of a research proposal. So first thing is identify a research problem, which I mentioned at the beginning. The next is to perform the literature search to know what is the current status and identify the knowledge gaps. And this will also help you refine your research question in a better way and formulate the hypothesis. Then you have to clarify your objectives and outcomes clearly and choose an appropriate research design that is relevant for your study. You also need to identify resources, expertise. Some of the resources may not be available. You need to acquire them. Some of the expertise may not be available at the center that you plan to conduct study. That may be solicited from outside the institute or even outside the country. And then identify the population, setting, sample, etc. I'll come to those things in detail. Again, as I mentioned earlier, relevant regulatory bodies approval may be required, and then you start your conduct of actual research. You also need to inform how the data will be managed and analyzed. the implication of the research to a larger audience, and how you will disseminate the findings of your research. All these needs to be put in your research proposal. So let's look at it one by one. The main structure, the body of the research proposal will be like this: title, introduction, methods, references, and annexures. So we'll go one by one. This is the title: the effect of intraoperative dexmedetomidine on post-craniotomy pain. Now, a cursory look at this title will not give an idea whether this is a case report, whether this is a retrospective study, whether it is a prospective study, whether it is an RCT or a systematic review. But if your title is more refined, more informative, such as this: comparison of intraoperative fentanyl with dexmedetomidine for perioperative analysis and opioid consumption during craniotomies. Here you know what is your study population, what is the intervention, what is the comparator, and what are your outcomes that you are studying. You also inform additionally what is the study design. Here it is a randomized control pilot study, etc. So the title page should have a title which should be self-explanatory. It should be focused, clear, and complete. Convey the research idea and design, which I showed you in the previous example. Indicate the key variables or the PICOT, and where possible, provide a short title or an acronym which will attract the readers to the research proposal. The researchers or the investigators' details need to be provided, and if the funding is obtained or you're applying for the funding, these details also need to be given in the title page. So this is the title page of one of the study that one of our residents wrote and applied for the funding, which was granted as well. Now coming to the introduction, this section should provide information on what you will do. So there is a problem statement. So you inform what is the burden of the problem and the context of the study. In general, it should acquaint the reader of the proposal with the topic that you are going to inform or conduct research upon. You should also set the boundaries, scope of research. You can, like cerebral, for example, you're looking at cerebral vasospasm. You should restrict the research or the information in this section to only that is relevant to that particular topic, rather than discussing entirety of subarachnoid hemorrhage. The next is literature review. Here you inform the current status of research on this particular topic or the problem. So you need to critically evaluate and synthesize the existing information by reading several articles on this particular topic. You should be able to identify end of it, the gaps that are there, and the reason for conduct of this study, and any conflicting findings between the various previously published studies. Now, when you do a literature review, you should look for the sources which are peer reviewed, which are current, which are relevant to the topic of current discussion. It should be published in the scholarly journals. It cannot be for some local journals which where the authenticity of the information may not be reliable. So it should be published in high impact factor journal, and preferably from the primary sources. You cannot cite a narrative review, which will take you back to the reference of the primary studies. So wherever possible, go for the primary studies, that is observational study or the RCTs, rather than for the narrative reviews. And avoid plagiarism. Now, this is very taken very seriously by regulatory bodies, by the editors of the journals. So wherever possible, perform a plagiarism check before you submit it to this ethics committee or scientific committee, etc. Now, this is just an example of how to conduct research. Depends on what you're looking at. If it is a quick research that is needed, you have to be very focused, very specific, using some keywords. Like here in the last one, you see that aneurysmal subarachnoid hemorrhage and cerebral vasospasm and remote ischemic precondition will return you only 6 articles. Whereas you do a broad search, subarachnoid hemorrhage, it can throw you around 30,000 articles. So which is very difficult for you to scrutinize, read, identify the details which are relevant for your research problem. So depending on how focused, how broad information that you need to perform a research search. Towards this end, the use of mesh or medical subheadings will greatly help in focusing your research to the relevant topics and give you very authenticated information as well. The next part of the introduction section will be the rationale or a justification for conducting the study. It should either expand the current knowledge or develop new knowledge or explore an unexamined issue. You should also inform the benefit of answering this question. The next section will be broadly the purpose or the aims or the objectives of the study. So when you talk of purpose, it is to just inform whether the particular intervention is likely to help in this particular problem. Whereas the aim is comparatively more focused and the objectives are very specific. The objectives are to be measurable. Whereas if I say that I am looking at the purpose of this study is to see if remote ischemic, the vasospasm is high in a particular population, and the aim of my study would be to see if remote ischemic preconditioning is likely to reduce the incidence of cerebral vasospasm, and my specific objective will be further narrowed, which is measurable. Like I'm looking at TCD flow velocities as a surrogate measure for vasospasm. So this is very specific, it is measurable. Whereas if you say I'm looking at vasospasm, I don't know how I'm going to measure it. So it should be very clear when you write the objectives. And also sometimes you need to inform what is your primary objective and what is your secondary objective, depending on the order of importance. And hypothesis, if you are mentioning, like my hypothesis in this particular study would be remote ischemic preconditioning significantly reduces the incidence of vasospasm. So here I am informing both the magnitude and the direction of the impact or the outcome that I am going to study. So these are the aims and objectives of the study that was conducted by us. Here we specifically mention the primary objective as incidence of vasospasm and intervention of remote ischemic preconditioning, and how we are going to measure it, the TCD parameters and angiographic parameters. And then we have listed certain secondary objectives such as clinical outcomes, for which the statistical power may not be always there. The next broad section is methods. Here you inform how you are going to conduct your research. It provides a work plan and describes various activities that are required for completion of the research project. Broadly for RCTs, it involves population, intervention, comparator outcomes, timeline, and design. So if you present it in a graphical format or a flow diagram, it gives a good idea for the reader how you are approaching your research. So here, if you can see the patient scheduled for surgical clipping of ruptured intracranial aneurysm, that is the population. I'm not studying endovascular intervention. I'm not studying subarachnoid hemorrhage patients who are not operated. So my population is very defined, well defined. And then I'm going to group them for or randomize them into two groups. Group is one is true RIPC group. The second group is sham RIPC. So I'm informing what is my intervention group and what is the comparator. And what is the study design? It is a randomized controlled trial. What are the outcomes? Vasospasm, biomarkers, cerebral blood flow velocity and oxygenation, and neurological status. And what is the timeline? I'm going to study them for 6 months after discharge. So that is the timeline. So this one flow diagram gives a complete picture of what is my research population, interventions, and outcomes. So when you talk of methods, you need to give more details in your proposal. These can be cut down when you are writing the main paper, but when you are writing a research proposal and submitting it to ethics committee or department scientific committee or a funding agency, these details should be elaborated to inform the reader what are the specific group of population that you are studying. Here I am informing that my age group is between 18 to 65 years of age, what grades of WFNS I am going to include, whether I am including all aneurysms or only antecerebral circulation aneurysms, whether I am including at whatever time point they come to the hospital or within 3 days of ictus. And I am again specifying that only those patients who are undergoing surgical clipping are going to be included. And then there are several exclusions which are not falling into the criteria of inclusion in this particular study. Then I'm defining my outcomes. What are my primary outcomes? What are my secondary outcomes? When I say primary outcomes, I am saying it is vasospasm as primary outcome. Now, vasospasm can be assessed in multiple ways: clinical vasospasm, TCD vasospasm, angiographic vasospasm. Here I'm informing them that I'll be doing TCD every 24 hours for day 7 to day 10 or until discharge, whichever is earlier. Angiography will be done at the time of diagnosis and subsequently any time during their hospital stay will be recorded. Clinical signs will be noted, but confirmation for the study will be done either on TCD or angiography. So I'm defining my outcome, defining how I'm going to assess my outcome. Similarly, biomarkers. Now I'm going to inform what biomarkers I'm assessing, at what time points I'm going to do. And secondary outcomes, again, similarly, has to be explained. Now in the methods, you also need to give some definitions. What is vasospasm mean? So this definition I'll be coming to the subsequent slides. Specific design information like RCTs, blinding, randomization, allocation concealment. So these have to be differentiated. Allocation, concealment, and blinding are not the same. So these have to be differentiated. For cohort studies, you have to define the outcomes, the predictors, any confounders that you're studying. And for meta-analysis, systematic review, how you perform the search strategy, how you extracted the data, what appraisals you have done, and how you have synthesized the results. So next, you have to also inform patient management procedure details, which are a standard. Like if I'm giving anesthesia for performing surgery, the standard anesthetic technique has to be described. If there is any specific interventions or procedure done for this particular study, that also needs to be informed here. Next, ethical details have to be informed, whether the Institute Ethics Committee is given, the patients are consenting or their caregivers are consenting, whether you are registered with the trial registry and which trial registry and what is the trial registration number. These have to be informed. And then the sample size, how you have calculated sample size. Several factors determine calculation of sample size. Most often it is based on the primary outcome because that is the most important outcome that you are studying. Second is, what is the precision that you are looking at? If your precision is very good or very narrow, then you require a large sample size. If your precision is broad, then a smaller sample size is sufficient. Sometimes the cost also determines the sample size. Now I want to do several biomarkers, but I may not have the cost. I can't charge the patient. In those situations, I may not have the funding. In those situations, the sample size gets proportionately reduced. Other common method used for calculating sample size is number of variables, especially for observational studies. Generally, for one variable that you study, at least 10 subjects or patients are required. So suppose I am assessing a post-operative cognitive dysfunction and I have 20 risk factors. I will need at least 200 patients to study this event. Event is a post-operative cognitive dysfunction. And lastly, feasibility. Sometimes sample size again is dependent on feasibility. Now, postdoctoral fellow who is pursuing his research for pursuing his training for 1 year will hardly get about 6 months for actual research. The initial time is spent on understanding the problem, designing the study, submitting to ethics committee, getting the approval, submitting to trial registry, getting approval. All these will take the initial 6 months. So the final time period for actual research will remain only 6 months or 5 months, especially the time period comes down if you have follow-up period. So the practicality and feasibility should be taken into consideration when you calculate the sample size as well. And then the funding and appendix has to be. I'll come to these steps in detail. So definitions, as I mentioned earlier, vasospasm. Now, vasospasm should be defined very clearly. So I'm defining it here as mean velocities more than 120 for middle cerebral, anterior cerebral, internal cerebral artery, pulsatile index of more than 1.4, Lingard ratio of 3, criteria for diagnosis of angiography. So I have mentioned it. What is slight narrowing, moderate narrowing, and severe narrowing. So if these are well defined, then there is no confusion among the researchers, especially if multiple researchers are involved. Then patient management. Again, patient management has to be clearly defined. How are you going to assess the cerebral blood flow velocity? At what time points? When will the blood sample be collected? How is the hemodynamic parameters collected? What are the parameters that you're going to collect? And your study intervention should be in detail. What is true RIPC? You have mentioned it as true RIPC, sham RIPC. Now you should define here what is true RIPC. Here true RIPC implies that 5-minute cycles, upper limb ischemia with 5-minute interval of free perfusion in between. The cuff will be inflated to pressure 30 millimeter mercury above the systolic blood pressure. And the sham RIPC, everything will remain the same except that the pressure will be inflated for only 30 millimeter mercury for 5 minutes. So these details should be easily understood by all those who are involved in conduct of the study, because in this particular study, the anesthesia technician performed this blood pressure inflation, because the outcome assessor, the person who was performing the TCT was blinded. The person who was assessing, conducting the diagnostic angiography was blinded. They should not be knowing what group the patient belonged to. And therefore, somebody independent who is not involved in these outcome assessment has to do the interventions here. And therefore, unless this is written down very clearly, the person performing these interventions will not be able to do that effectively. So the next is the ethics and registration. Whenever you are asking for a consent for either a volunteer or a patient to be part of the study, remember that they are doing it voluntarily. They are giving their time, they are subjecting themselves for any interventions or any methods that you're going to do on them. So we have to value their consent, value their time, value their contribution to the study, and acknowledge them. And therefore, all their safety, ethical aspects have to be taken care of. Confidentiality have to be maintained, and transparency at the same time has to be also be ensured by registering the study with the clinical trials registry. The next important and often what we find difficult is the sample size calculation. There are several ways of calculating sample size depending on the study design. So here is a pilot study. 12 patients per group for an RCT is sufficient because there is literature, epidemiological data to suggest that you will be able to find feasibility of conducting the larger trial if at least 12 persons are in one group for the pilot study. But if you want to do a main study and you have prior studies available, especially if you are looking at quantitative data, such as here fentanyl consumption. Now here we are looking at fentanyl consumption between patients receiving skull block versus incision site infiltration. And previous studies inform me that the fentanyl consumption was 1 microgram per kg per hour in patients who received skull block versus 1.39 per group per kg per hour for the incision site infiltration. And I calculate the effect size for this, and based on the significance level that I set and the power, the sample size requirement can be calculated. Now, if you want to inflate the sample size, especially some patients, you may not be able to assess post-operative pain because the tube is retained. And based on your 3 months previous data in your hospital, you find that 15% of the patients are likely to remain intubated after surgery, and therefore their post-operative pain scores cannot be assessed, and you need to inflate your sample size by 15%. So the total sample size will be higher than the sample size calculated based on the difference between the two groups. Similarly, if you want to say compare the incidence of delirium. Now this is proportion data. So if you have proportion data saying the incidence of delirium in craniotomy is this much, incidence of delirium in spine surgeries is different, and then you want to conduct a study in your population, again this data can be used for calculating the sample size. And various online tools are available which are listed here. A couple of them are listed here. You can use the numbers that you derive from the previous study or from your own pilot study and apply them in the statistical calculators that are available online to derive a sample size. Those of you who wish to apply for funding to any agencies will require to provide the details of budget, and it can include salaries, it could include consumables, travels, equipment costs, and if your studies are spread over multiple years, then every year what are the budgetary estimates have to be provided. Many funding agencies ask for the justification. So your justification has to be sound, has to be rational, and has to be appropriate. Only then the chance of availing the funding are higher. The next and the most important part of your study would be the data. So you have to be very clear on this, how you are going to manage your data, who will collect the data, when the data will be collected, where it will be stored. Similarly, when it comes to the item that you are studying or variable that you are studying, if I am studying the several variables for post-operative cognitive dysfunction, whatever variables I am using, they should be reliable, they should be appropriate. I can't say that a person watching TV is likely to have post-operative cognitive dysfunction. That is not appropriate. But if I say that patient having a catheter, bladder catheter, is likely to have a more post-operative cognitive dysfunction, that is more appropriate. These variables should be proven in earlier studies, or it should be strongly clinically suspected has to be responsible for an outcome that you are going to study, and these should be available as well. Outcome measurement, suppose you are doing post-operative cognitive dysfunction as an outcome, you should inform who will perform, when it will be performed, and what instrument you will use to perform that. Suppose CAM is one of the tool that is used for assessing post-operative delirium. This should be available. It should be validated for the population that you study, and we should define when this will be performed. So if I'm going to perform on a first post-operative day, my outcome measurement, this has to be informed here. How is the data going to be managed, and where will be storing the data, what format will be storing, who will have access to the data? These details have to be provided here. And lastly, the analysis plan. I'll come to that in detail. We also need to provide a pro forma of how we are going to collect data. If you have this at the beginning, it makes life easier when you are actually conducting the data without missing out on any of the items and later realizing that, okay, I forgot to collect this and I should have collected this particular thing. You will not be able to do it because there will be a lot of missing elements when you are going to analyze the data. And you also need to inform the significance when you write the method section. What are the implications of your study and what are the anticipated outcomes that will enhance the credibility of your research proposal. Now, statistical analysis is the portion of the methods that most of us are uncomfortable, inexperienced with. We can take the help of the statistician, and this has to be done at the beginning of the study when you are writing the research proposal. Most of the times what we see is we conduct the study and then go to the statistician and ask them to do the analysis. That is the most inappropriate way because they will not be knowing what is your methods details. You will not be understanding the statistical language that they use. And then somehow some statistical jugglery will be performed and some results will be presented. It is ideal that you approach a statistician, you explain to him what study you are going to do. This is the study design that I am employing, and these are my outcome measures. I want to identify the tools that we are going to use, and then they will be able to give you all these details. So what tool that you are going to use to perform an analysis, how are you going to test for the normality between the variable between the groups, and how are you going to analyze your quantitative data if it is normally distributed, if it is not normally distributed, how are you going to analyze your qualitative data again if it is normally distributed or not, what should be your level of statistical significance. All these details have to be informed under this particular subheading. Lastly, I personally believe that the research takes a lot of efforts, involves a lot of manpower, a lot of resources, material resources, money, and most importantly, the person whom it is going to benefit, that is the patient, who volunteers to be part of your research so that a larger scientific community, larger patient population benefits. And therefore, it is important that you share the findings of it. You complete the study. I find that many of the times you don't complete the study. Even when the study is completed, they are not presented in conferences or not published. And that is a waste of resources. That is a waste of research. That is a waste of time of the persons involved in research as well as the patients. And therefore, we should aim to share the findings of our research to the larger audience, especially in terms of publication. Lastly, a lot of annexures need to be attached to the research proposal. It could be references, it could be cover letter, undertaking, information regarding manpower, materials, and money, approvals from various bodies such as Department Scientific Committee, Institute Ethics Committee, then pro forma, the consent forms, and instruments, especially if you are doing very specific in terms of like MMSC or CAM for particular outcome assessments. This, I think most of you will be familiar, but these are the minimum things that should be present in your consent form. The title, introduction, purpose of research, highlighting the voluntary nature of participation of the patients or the subjects, what interventions you are going to do, the risks and benefit that patient is likely to achieve by participating in the study duration, reimbursement, whether you are providing any monetary benefit to the patient, confidentiality, again, very important, that how are you going to de-anonymize the details of the patients when you are taking, when you are performing the analysis or disseminating the findings of your research, and request for participation, and then the consent signed by the participant, witness, and the investigator. Now, we should also at this point of time plan how we are going to present your research, how many tables, because this is important. In the thesis, there is no limit on number of pages or number of figures and tables. But when you are publishing the same findings of your research as a manuscript journal, there are certain restrictions imposed. It could be a total of 6 figures and tables. So you need to have something in your mind, like how you are going to present your research. A flow diagram is invariably asked depending on the journal that you submit, or even otherwise, it is good that you present the patient recruitment as a flow diagram. And minimum tables of figures are required for demographics and for outcomes. You should also plan how we are going to write your discussion. The most fun first paragraph should be devoted to writing of summary of the findings. The second, you should compare your findings with that of the previous literature. for each of the outcomes that you are highlighting. And then there should be subheading for strengths and limitations. Acknowledge the strength of your study, acknowledge also the limitations of the particular study. And then you can suggest the scope for future research and conclude by informing and summarizing the findings of the research. Now, what are the reasons for unsuccessful proposals? They have been listed here. The problem is of insufficient importance. Now, I want to study OT1 versus OT2, the infection rates when all care elements are remaining the same. Now, the problem is of not sufficient importance. It is not rational. It may not be accepted by your ethics committee or scientific committee. Or the problem is too complex than what you're proposing. You are saying that I am looking at post-operative cognitive dysfunction at 1 year, and you are not taking into any factors beyond hospital discharge. You are only focusing on intraoperative anesthesia details. The problem that you're studying is more complex than what you're proposing. So it may not find traction amongst the readers and the stakeholders. The purpose or the need of the study is very vague. I want to study hyponatremia in the ICU. Now you're not clear what is the hyponatremia you want to study, which population you want to study, when you want to study. ICU is a long period. So the purpose is very vague unless you explain in detail in the methods. Hypothesis is unsound or doubtful. In the same example which I give, hypothesis that OT1 infection rates are to be lesser than OT2. It doesn't make sense. Assumption validity. You make a lot of assumption. You say that a patient operated in OT1 is likely to have less infection. Now, this is an assumption. This may not be accepted by the department scientific committee or ethics committee when you submit this as a proposal. The approach is non-rigorous. It's very subjective. You start with I will look for this. Previous studies has shown this, but I find that this is not so. You are not approaching the problem objectively. A lot of subjective elements come into play, and then this study proposal is likely to suffer. The methods are poorly described or unsuited for the stated objective. Now you want to say that mannitol is superior to study mannitol, superiority of mannitol over hypertonic saline, and you say I will do a retrospective observation study. That is not the ideal or the best study method. Ideal would be a randomized controlled trial. And you describe the methods very poorly. You don't explain which method you are going to do, what timelines, whatever we discussed till now. If these are not there in the proposal, it is less likely that the funding agency will be interested. Department scientific committee will likely to send it back to you for revision, and it will unnecessarily delay the process. So for a 1 year PDF candidate, if 8 months are spent on going back and forth in improvising your research proposal, there is a lot of waste of time. Then the rationale, as I mentioned, is poor. The logical processes are not followed. And lastly, the budget, the manpower, the material, the money is not justified or inadequate. Now you say I want to do functional MRI to assess the cognitive dysfunction, and you don't have capacity in your hospital to do functional MRI, then the whole study proposal falls apart. So you'll not be able to conduct this study. So these are some of the tips for successful research proposal gained over a period of time with experience. You should know your audience. The proposal needs to be tweaked for conference, tweaked for publication, tweaked for the department scientific committee, tweaked for the ethics committee. Ethics committee, remember that most of them are non-medicos. They are general audience, patient advocacy groups. So they may not understand your scientific terminology. So you should know your audience and write the proposal. Demonstrate expertise in research and in the concerned field. Now, you might have published in some particular area, highlight those areas. If you have some or your department colleagues have published studies relevant to the problem that you are now going to study, show that as a department having expertise in conducting the research in that particular field. Provide proper context to frame research question. This I have already discussed. Cite previous work, again mentioned. Focused on the research question. The research question is the most important. It should be very, when you formulate a research question, lot of thought, mind has to be applied. Develop coherent argument for proposed research and have clarity. Don't focus on minor issues and leave the most important ones. Good writing. The common problem I have found as a reviewer is that The writing is very poor. Basic grammar and syntax are not adhered to. That demotivates the reader to go into the details of the proposal. He will send it back to you, improve the language. Provide important details in the required format. Most of the time, especially with regards to Ctri registration, they will just send it back to you. It is not in the proper format. The guides details are not in the scientific question and the public title, both are the same. Make the title more relatable to the public. So back and forth, the trial registration date goes further, and you will not be able to recruit your first patient before trial registration. Justify the need for this project. The justification for conducting of the research is very important. Unless that is satisfactorily addressed to the needs of the reviewer or the reader, again, that may not find traction among the readers. So to conclude, research proposal is like a script of a movie. So unless the script is good, the movie is less likely to succeed. A good proposal helps in both smooth conduct of research and also yields good outcome in terms of success of completing of the project, in terms of success of acceptance of your study results by journals. So writing the research proposal is both an art and science. It can be improvised over a period of time with experience and writing. So prepare, practice, and peer review. Send it to somebody in your department, some senior colleague, somebody who has experience. Let him review it and give critical comments, which will help in improvising the research proposal. Bottom line is the research proposal begins with the present. You know, current problem at bedside. You go back to the past, perform the review of literature, and then provide evidence for future. So with this, I conclude, and as I mentioned to Dr. Zulfi, it would be good to have an interaction and address specific questions that the trainees might have. I'll stop sharing here, and then maybe we can have a discussion. Is that okay, Dr. Zulfi?
Yeah. Thank you, Dr. Sriganesh. You have covered the topic so nicely. I would like our students, our postgraduates, to participate actively. Dr. Sriganesh is an authority on has done very quality research in neuroanesthesia. So I would request our postgraduates kindly interact, clear your doubts. This is one of the fields where we have not enough knowledge, where we do not get properly trained during our graduation and post-graduation.
Hello, Sriganesh. Till the postgraduates get over their shyness and form the questions, I'm just stealing the time. Just wanted to ask you, first and foremost, Sriganesh, that was a very informative lecture. Can you hear me?
Yes, madam. Please go ahead.
Just I wanted to ask you. You said about the statistical analysis that don't depend too much on the statistician. So, what do you suggest to the newer people, like the newer researchers? Should they? Is there a simpler way of learning stats and without getting overwhelmed with it? Do you have any recommendations, or maybe how do they approach this if they don't want to? Because everyone's heavily dependent on the statistician, and the way they turn them around, they get turned, including all of us. We like to believe that they are the authority. So, do you have any tips for them? Should they prepare themselves on statistics if they want to undergo a good quality research? That is my first question, and I have another one for you.
So one way of approaching this statistics for a research project is, as I mentioned, plan it out at the beginning itself, when you write a proposal, rather than after the completion of the study. Now, not all of us have expertise or experience in all kinds of statistical analysis. Most of us but should know the basic statistical analysis. We should know what statistical tests to employ in which situations. And most of these can be acquired with the reading basic statistical textbooks. Of course, in the initial stages, it might be difficult. You may have some doubts. It is always better to write them down and interact with the department, biostatistical department, and clarify. They will be more amenable to answer specific questions rather than taking a whole lot of data and going to them. So I have found that to be more successful in getting their attention and time. So I do the preliminary analysis and then go to them and ask them, okay, this is what I have done. This is my research table. Are you okay with the result that I have done, the statistical test that I have applied, or do you think that more needs to be done? So that is one approach. Second, there are some online tutorials available which you can subscribe to, or even the ICMR, NIC, National Institute of Communicable Disease, and National Institute of Epidemiology in Chennai. I think all MCI institutes teachers need to undergo this training. And nowadays, I believe that all the institutes emphasize on basic research methodology training at the beginning itself, wherein one of the class will be on statistical analysis. So basics test, when to apply t-test, when to do ANOVA, when to do other statistical method. These basic knowledge should be there. Of course, the higher level of statistical knowledge is difficult for us, difficult to understand and interpret also. But one more suggestion which I can give to in the initial phase, what I learned, how I learned is by reading the journal articles. Now, reading journal articles will give us more information on what kind of studies, what kind of data, what statistical test to apply. And that is one way of learning independently. And then again, of course, taking the help of seniors. So one, online tutorials. Two, reading the journal articles. Journal clubs should be taken seriously. Most of us don't take journal club seriously, and especially on the method section and the statistical analysis. And third one is, of course, doing the preliminary analysis and going to the statistician for clarification or improvisation. These are some of the tips I can suggest for the learners and beginners. Those who are
Sriganesh, I would also like to add here, we have a specific 1 year back, 2 years back, we came with a dedicated issue from Indian Journal of Anesthesiology that was devoted to research methodology.
correct. Yeah.
So many of our faculty members, most of our students, they should go through that issue that has been prepared after a lot of hard work. And it has been prepared by leading national and international authorities. And it almost addresses most of the basic issues that an anesthesiologist encounters in day-to-day clinical practice.
And one very quick question, which is from the students' side only, from their aspect. When they give their results, there's a plethora of ways in which you can make diagrams, pie diagrams, or anything else, or a first plot or something. Is there a way of defining how would you depict your or how do you present your results? Is there a norm for it? Just a shortcut? Because I found this very confusing. They would say, okay, we would put our results like this, or somebody would try to make attractive diagrams or something. But can anything substitute the other one, or there are certain guidelines for this?
I have been reviewing some of the theses sent to me, and I find that most of the time there is duplication. Somebody will present the same data as a table and also as a figure. Now, somebody who is the knave will not pick it up, but somebody who knows can at the cursory look say that you have presented same thing in a different way. So it doesn't make sense. So there is no need to present or duplicate the same output or results in a different way. And regarding particular either in a tabular format or as a figure, it depends on how precisely you want to share the results. Suppose I want to share the serum sodium values over a period of time. It can be presented both as a table, also as a figure. But in the figure, I may not be able to give the precise values. I can only show it as a mean value and maybe a standard deviation as a graphical format. But if I present it as a table, I can give the precise standard deviation and the stipulated mean values. And that is more easy to understand for the regular readers who are not thorough researchers. But figures do present data in a colorful way, which may attract the readers to or bring the attention of the readers to the directly to the result section. So it's okay. There is no one particular way of presenting your data. It's up to the researcher, up to the individual, how you want to present. But as I said, the only dictum is don't duplicate it. That will unnecessarily take away the limited resources, limited numbers. Suppose you have only 6 or 7 tables or figures to present, you will not be able to present everything. some data has to be presented in graphical format or figure format, like flow of the patients. It cannot be in a tabular format. So some basic rules have to be applied. Otherwise, it doesn't make great difference to present data in either tabular format or figure format. The pie chart, bar diagram, the 3D bar diagram, that is all the imagination and how you want to. That's all.
Thank you so much. Now I'll make space for the students now.
Dr.
Thank you.
Sriganesh, there's a question in the chat box. Is it necessary to have an index study to calculate the sample size? Can you just kindly answer?
Okay. So if there is a previous study, it helps you in calculating sample size. As I mentioned in my presentation, you can calculate the effect size, and then depending on the need of the statistical significance that you want to achieve, you can calculate the sample size. If that is not there, if you don't find, sometimes I have seen, even I was a part of the PhD review here, and I found that one of the PhD proposal, they were looking at language as effect on the cognitive function. The hypothesis of that multilingual, more than 2 languages somebody knows, his cognitive function is likely to be better in post-stroke patients as compared to a person who has only 1 language. And the sample size they calculated was based on the age, which has absolutely no connect with the outcome. Now, that is not the way to connect a sample size. There may not be previous studies to help you in calculating sample size on that particular question, multilingual or monolingual, or any for that example, for that matter. In that case, you need to have a pilot study on your own. You do it in, say, 5 patients if you are doing a comparative study, or if you want to do some calculate the prevalence or something, do it in your own level. And remember that these can be included in your main study as well. These patients can be included in your main study as well, provided there is no deviation from the method that is described at the beginning. So that will not go to a waste. So index case will help you in calculating sample size. Otherwise, you have to, your study will become more of an exploratory in nature. Now, I did a study where we looked at functional connectivity after propofol in patients, healthy volunteers. So we don't know how many patients are required. It's purely exploratory in nature. So we took a minimum number of patients based on the feasibility and the duration, so and the resources. So these can be used, but otherwise in non-exploratory quantitative studies, it is required that your sample size is defined a priori. A priori means before the start of study. And for that, either you should have a previous study to explain the sample size that you are calculating, or results of your own pilot study.
Thank you, Sriganesh. And we have one common myth that once we are doing a literature review, one of the students is asking that, is it mandatory that we have to have a minimum number of studies before we proceed working on a particular topic?
No, see, it's very difficult. Certain very focused topics may not have any studies, whereas some general studies may have thousands of studies. So there is no such thing as minimum study or a maximum study
that are really required.
Yeah, I don't think so. It should be relevant, it should be apt, and it should be very focused to the questions that you want to answer. I think that should be the core.
Any other question from any of our students? Any other queries?
Sir, I have a question regarding the sample size. I am Dr. Priyanka from GB Pant.
Yes, madam.
Sir, I would like to ask, suppose regarding the sample size again, suppose I want to calculate a sample size in accordance with my primary outcome. Now, that primary outcome is a normal clinical parameter. Suppose, for example, we can take peak airway pressure. So, for me, clinical difference of peak airway pressure of, say, 3 centimeter or 4 centimeter of water is significant. So, can I take that difference as the basis for calculating sample size, or do I need to have some study? Then only I can calculate.
Yeah, but your outcome should be of significant importance. So now you are talking of there. Okay, I'll just slightly deviate from the specific question. we look at, you are given an example of ICP. Okay, so I'm sorry, peak airway pressure. So peak airway pressure difference of 5, you say is significant, but we don't know whether that 5 is between 45 to 50 or 20 to 25. Now that becomes a problem. So for that, we should have a deviation from the normal. The difference of 5 should be from close to the normal to say it is abnormal. Now, what do you consider as abnormal? Say some say 25, some say 30. Suppose you're taking as 30, and if the difference is 35, then I would consider as significant, clinically important difference. Then it is fine. You don't have to have a previous study. But of course, the question will come: how did you come to that number? Why do you say that peak airway pressure of 35 is likely to harm the patient as compared to 30? For that, you will need to have some reference. So that way, you go back to previous studies to search for a significant difference. Now, 35 may not cause any problem, no barotrauma, 30 may not cause barotrauma or any other outcomes, clinically important outcomes. The peak airway pressure is not important for the patient. As a researcher, you find that that is important. For the patient, what is outcome is the consequence of high airway pressures, such as barotrauma requiring additional interventions or longer hospitalization. That should be our focus rather than looking at some difference in outcomes. Should be not be predominantly focusing on phenomenology.
Okay.
But you can do studies like that.
Okay. Thank you so much.
Any other queries? Dr. Sriganesh, for for the benefit of our postgraduates, can you just give a brief idea about the allocation, concealment, and blinding, because this would help them a lot once we.
Okay. So the blinding, again, as a reviewer, I see some of the teachers here, so they would have reviewed several articles. Most of the studies will mention single blinded, double blinded, triple blinded, without informing who are blinded. Now it's important rather than single, double, triple to inform who are blinded. So when you say blinding, it means that some person is not aware of what intervention is being done on him or her or in a particular subject. So we should specify whether the patient is blinded, whether the clinician attending to the care is blinded, whether the data analyst who is performing the analysis of the data, whether he is blinded or the outcome assessor is blinded. Why is blinding important is because there is significant element of bias if the blinding is not there, which can influence your result. Suppose, simple, I want to compare fentanyl versus dexmedetomidine for analgesia. Now, unless I am blinded, I am likely to influence the result as an investigator. To avoid that, the blinding has to be done. The patient also has to be blinded because pain is a subjective thing. Now you tell him that I'll give drug A and I'll give drug B, and if he comes to know that drug A is commonly used in the hospital and it relieves pain, and drug B is a experimental drug, he is likely to it is likely to influence the way he informs pain scores to you. And the same thing for data analyst. Now data analyst should also be blinded because otherwise he is again, if he has some knowledge about the clinical study, he will also try to fit in the analysis to the requirement of the researcher or a student. And the fourth person, as I mentioned, was the clinician. Now clinician also has to be blinded. Suppose I am the clinician and you are doing a research, and you tell me that don't give, this is a very strict protocol of giving fentanyl to all patients, and as a rescue you have to administer this. Now, if I am knowing that this particular patient is in one particular group, I may intervene early or I may intervene late. So I may be biased, and that can influence your final outcome. And that is the reason why blinding is essential, and you have to inform who all are blinded in your study. Of course, if you are comparing fiber optic versus video laryngoscope, you cannot blind the patient or you cannot blind the clinician. So wherever possible, blinding has to be done to reduce the risk of bias. Second was on
Allocation.
Yeah. So the allocation concealment and blinding are two different. In allocation concealment is predominantly for a randomized controlled trial. The randomizing sequence is not known. I know there are two groups, but I don't know in what order the patient is receiving a particular intervention. It could be sham versus true. Suppose I am doing a BP inflation, the order should not be known to the person who is implementing the randomization, and that is known as allocation concealment. Again, that has to be centralized so that the only person, when he performs that intervention, just before that, the information is shared, so that it cannot predict the order. Basically, it is to conceal the order. I should not know if I get normal saline now, whether I'll get a balanced solution next. That order should not be known to, again, minimize the bias.
Thank you, Dr. Sriganesh. I don't feel there are any other queries. Dr. Montorio, sir, would you like to add some?
No, Dr. Sriganesh, thank you very much. That was a very good talk.
Thank you.
And I think you covered all the aspects very well. Can you just tell them the importance of the CTRI number now? Because none of the index journals accept unless there is CTRI number. So just the importance.
Now, I think I'll categorize in multiple ways. One is it is mandatory as per the Government of India ICMR directives. CTRI registration for all interventional studies is mandatory. It can lead you into medical legal problems as well if you are not registered. That is first. Second, as a part of CTRI registration, you have to write a proposal a priori before the start of the study. 10 years back, 15 years back, when we used to do studies, this was not there. We never used to write a proposal before study. We should just start the study. Somebody used to collect, somebody used to submit the data, somebody used to do present the results. So that is no longer possible. Publication in a trial registry like CTRI will enhance the transparency. It will also help you in conduct of the research. You will not deviate from the research. So that is another byproduct of registering the CTRI. Third, the final outcome of any research is publication in scientific journal. It helps you in your career growth. It helps in dissemination of the scientific knowledge and helps in improving the care for the patients. And most journals, like sir mentioned just now, insist on trial registration, and most of them will not entertain journal, will not send even for peer review unless you provide them with the trial registration details. So these are some of the key reasons why you should register with the client trial, and do not start the study without the trial registration. Earlier, say 6 years back, when it was started, it should take months. Now it is generally given within a couple of days, provided all details are submitted correctly. So these are some of the reasons why you should study the importance of CTRI registration. As of now, it is mainly for trials, only for trials. It is mandatory, but the CTRI also accepts proposals for observational studies also, and it is desirable that you submit your observational studies also for CTRI registration, because some journals will again ask for you, despite informing them that it is a non-interventional observational study. Maybe only for retrospective, none of journals as of now insist, but for trials, yes, you should register.
And the other thing is, can you suggest some free plagiarism checks for the students so that, before they send it to the editor and the reviewer, anything that is freely available, which do you recommend for them? See, most of the ones that we use, they cost a lot of money.
Yeah, I don't know.
Can you suggest, what do you use?
Our institution has Turnitin, which that is available free of cost for all our students here. So that problem does not arise. But the worst case scenario, when you submit to journals, see, again, free versions have limitations. Most of the free versions can accommodate up to 1,000 words. So you copy paste 1,000 words in multiple terms and then calculate the similarity index and then inform the journal. That is one shortcut I can suggest. Otherwise, some of them give you at one-time trial free access. So you can put the whole entire manuscript into that and then submit it, and then they will give you the output, the plagiarism, the percentage. But subsequently, you can't use the same one. I don't know, because I have maybe others who are using free versions who don't have access to the paid versions can find on that. Dr. Zulfi?
Okay.
Yeah, basically, I also use paid version. I don't also
Yeah,
use
maybe.
free version. And really, if we have done written an article nicely, the need really does not arise. As editors, as associate editors of IJ, we're using, but we're using a paid version from the IJ.
Correct.
As an author, I have never gone for it.
Yeah,
Really.
the plagiarism check, if you search on Google, you will get. I mean,
Yeah,
are more
Google itself detects.
Yeah. And
Yeah,
most journals also do a plagiarism check.
Yes.
And
all of the journals are now doing, all quality journals are doing. In fact, from IJ now we have initially we were using the paid versions, free version, but now we are using a paid version just to increase the quality of the articles.
Correct. And most institutes, at least teaching institutes, should acquire a plagiarism check software at their level, just like any of the library other access like EndNote or reference manager they have. Even plagiarism check software should be purchased by the teaching institute, because a lot of students will need it, use it. And in our institute, it is mandatory to submit plagiarism details for thesis before it goes for review by the external faculty.
Thank you. Another comment I'd like to make is that students should take research little more seriously, and sometimes the style of writing comes across very casual, and the language is very colloquial. So, and as Dr. Sriganesh mentioned, spelling errors, syntax errors, you get a desktop rejection. People will not bother to even go beyond the title. So better to run it through some other experienced researchers in your department or your HOD or your guide before you even dare to send it for a review. Because then, and multiple rejections are common. Don't feel rejected or dejected if you get a rejection. You have to sort of try to improve yourself. Take that as a feedback from these reviewers and try to address those issues rather than getting controversial, into a controversy with them and rebutting whatever is the query. Try to find out how you can improve your work. I think, thank you, Dr. Sriganesh.
Thank you, sir.
It was very informative talk.
Thank you, Dr. Sriganesh, for sparing your valuable time. Thanks a lot.
Thank you. I hope the students will have some renewed interest in conducting good research. Now, that is important.
Yeah.
And not just students, even teachers learn from your lectures. So thank you so much.
Okay, thank you, madam. Thank you.
Hello.
Thank you, Dr. Sriganesh.
Okay.
Thanks a lot.
Yeah, thank you very much. Okay, bye.